Welcome. I'm pleased to see you all here, and I'll introduce myself. I'm Dorje Jennette. I'm the clinical director at UC Santa Cruz, and I did work at UC Davis a couple of years ago, where I actually spent most of my career. And so I'm sharing a presentation that I initially developed at UC Davis and further developed at UC Santa Cruz. With one of my trainees, P.O. Kim. He contributed some of the slides, so I want to credit him on this. I do want to point out that there is a toolkit associated with this presentation, and at the bottom of this first slide is the URL for the toolkit. You can grab some handy resources. I'll mention them later. But basically, you go to tinyurl.com/QHWTM9A. I'll show that again later in larger font, so you should be able to get it at some point. And I do want to say that my intended audience is largely those who may not have the resources to do full batteries of ADHD and ADHD testing. Those of you who may have the luxury of resources to provide a full battery may not have much interest in changing because you have that luxury, but hopefully everybody will get something out of this presentation. I do have some learning objectives, one being to describe factors complicating the ADHD diagnosis, and those factors can be social justice in nature, but certainly there's the validity issue that can come up when there are some motivating factors to get the diagnosis of ADHD. And so we'll be talking about some of the emerging opportunities in ADHD testing, such as validity testing, and the use of computers to administer the tests so that you don't take away as much time from clinician resources. And we also want to review recent research developments in the realm of ADHD diagnosis, largely related to the validity issue. One of the main goals, as I alluded to, is social justice regarding the identification and treatment of ADHD, and pursuit of that while preserving time for direct care and minimizing charting and referral burdens that can come with doing ADHD testing. Some of the social justice issues can be illustrated through looking at just the rates of diagnosis. So many of you may already know that the baseline prevalence, according to the DSM-5, is that about 5% of children and 2.5% of adults have ADHD in the United States. And about 30 to 50% of the children who have an ADHD diagnosis mature out of it as they enter adulthood. One estimate is about 15% still meet the full criteria in adulthood. And that presents a challenge for us working with traditional college-age students who are traditionally entering adulthood as they enter college. They may be maturing out of a diagnosis, and so it falls upon us, if we're treating the disorder, to establish the validity of the diagnosis, even if a student was diagnosed in childhood. And if you look at college rates in particular, the college prevalence on a national scale from the NCHA survey of 153 colleges and universities, over 100,000 students with a 34% response rate, you find that 7.6 of those in the survey reported having ADHD. And we have data from UCLA showing that about 5% of the first-year students report having an ADHD diagnosis. It's similar at UCSC, UC Santa Cruz, where it's 5.6 of the undergrads and 4.65% of the grad students reporting have ADHD in the 2013 survey. And so one question may arise, why are the rates lower at UCLA and UCSC and probably other sister campuses in the UC system lower than the national average? And one hypothesis I have is that it gets into the social justice issue of there perhaps being more diversity in our student bodies. And so I'll get to some evidence for this hypothesis in a moment. But one interesting thing is that despite those rates of qualification for the diagnosis, we see some evidence of ADHD possibly being overdiagnosed. When the CDC looks at students who, or children in general, who are diagnosed with ADHD, it's about 9.5% between the ages of 4 and 17 years old, given the diagnosis. And that can be from general practitioners, pediatricians giving that diagnosis. And you do see a significant discrepancy between boys and girls. Of course, boys having a much higher rate of diagnosis, and as you may know, that can stem from boys more commonly having the hyperactive variant of ADHD and that being more visible, and girls being less likely to be detected as having ADHD. When you look at the CDC's data on disparities among racial identities, it's interesting to note that folks who identify as Asian have a prevalence of only 1.4% of the diagnosis and of ADHD, and among those identifying as Hispanic, the U.S. government designated identity, it's about 5%, and that's in contrast to the non-Hispanic white and black rates being around 10 or 11%. So it is possible that there is an issue of some cultural groups not adequately being diagnosed with ADHD and others possibly being overdiagnosed. I mean, I think it's commonly accepted that there is both an overdiagnosis and underdiagnosis. And so we're talking about an accessible way to test and remove some of the biases that may exist in identifying. And so one way to further examine this hypothesis is to look at the rate of diagnosis in the nation. If you look at this color-coded graph here, you'll see more of a tendency for there to be a higher rate of diagnosis in the East and less in the West within the U.S. And if you look at the population identifying as Hispanic in the U.S. government designated identity, you see a bit of the opposite trend in the population distribution. And so if you toggle between these two, you can see that it's almost a polar opposite there, where with a higher percentage of the Hispanic population, you see a lower rate of ADHD diagnosis. And this is similar if you look at the percent of the population identifying as Asian as well. So you get populations that have lower rates of diagnosis, perhaps skewing the overall rate of diagnosis in those states. So before we move on to the next slide, I will say one of the additional pieces of evidence I've come across is just talking with folks, for example, a woman who identifies as Latina described suspecting that a family member of hers had ADHD, and just growing up with parents that had no idea that it was even a diagnosis, or not even knowing what resources there were to address the concerns that this person's relative had. And so our UC system can be an opportunity to help students who may not have had the support in their families to address their possible ADHD. So we can be a useful resource. Another major justification to provide testing with validity testing included is just this case example that the New York Times headlined, Richard Fee drowned in a stream of prescriptions. This is Richard Fee. He was the college class president and an aspiring medical student, very intelligent and articulate. But he did convince doctor after doctor that he needed medication for ADHD. And without testing, the physicians tended to issue a hasty diagnosis of ADHD. And even psychiatrists involved in his care continued to just prescribe the medication and even increase the dosages despite evidence of his growing stimulant addiction and psychiatric breakdown. Even his parents telling the prescriber, "You're going to kill our son." The parents, did what they could, but the prescriptions continued. And this, to be fair, was a very smart and convincing young man. But he did ultimately develop symptoms of psychosis, and he was so addicted to stimulants that he would get overheated from using Adderall or whatever, and was putting ice packs on himself to cool himself down, and ended up hanging himself. So his parents, as far as they know, did not sue the prescribers. They just really became advocates for a better system to diagnose folks who think they have ADHD. So no testing was involved in this case. And in fact, there are no national standards from any governing body saying that you have to do psychometric testing in order to issue the diagnosis of ADHD. Some of the emerging standards that seem to be there come from, for example, the ETS, the Educational Testing Service, which administers the SAT and GRE, among other exams. They do have standards for accommodations on those exams. And these are simplified, but in general, they would like to see something completed within the past few years by a specialized psychologist or a psychiatrist with firsthand childhood teacher comments, for example, third-party evidence of current impairment, a rule-out of alternative diagnoses, and relevant testing like IQ, achievement, attention, and so forth. There's a set of standards as well for NCAA students who have been prescribed a stimulant medication. There is random testing of NCAA athletes, and if stimulants are detected, it's expected that they have documentation showing that it's a legitimate treatment for them. Their standards are less specific than ETS, but it's similar in general. And our own UC Santa Barbara contributed to emerging standards through, in particular, talking about the need for validity testing, which would essentially help distinguish between students who are malingering or through some other avenue having inadequate effort, and those who truly do have ADHD, true impairments and symptoms. That was in a conference call back in 2012. And with the question of malingering, one of the major issues is incentives, and I think we all know that there are incentives to get an ADHD diagnosis. And for one thing, it's one of the least stigmatized diagnoses. Plenty of people seem to feel pretty comfortable identifying as having ADHD. And certainly if they're struggling academically, it's a convenient explanation for what's happening. But the base rate of probable malingering in a sample of individuals completing psychoeducational evaluations has estimated to be about 10% when external incentives are present. So certainly for ADHD, the incentives could be the prescriptions for stimulant medications that not only could enhance performance for someone without ADHD, but also could be used recreationally and become a valuable commodity in the illicit marketplace. I've heard stories, and I'm sure some of you have as well, of students paying for rent by selling their prescriptions, that sort of thing. One particular validity test that we employ and we selected because it is computer-administered is the Victoria Symptom Validity Test. And there's research showing that a cutoff score of 19 for one of the particular measures shows you about, it basically shows you most of the students who are putting in an adequate effort without falsely identifying anybody as, malingering. And by the way, malingering isn't as widely used as a term in this context. It'd mostly be framed in terms of effort, sufficient effort or not. So that, translated in more technical terms, is that this test has a sensitivity of 0.8 and a specificity of 1 with a cutoff of 19. And without breaking the test security, I can illustrate the general principle that this test uses through something that's actually nearby, the Disneyland reference here. So the example to illustrate would be, you just memorize the image on the screen, and then I'll show you 2 images, and you decide which was the one you just saw. So between these two, almost everybody would, correctly identify this if they didn't have some incentive to do otherwise. And this is rated as a quote-unquote difficult item because you basically have images from the same species here. So a lot of people would think, oh, they're so similar, it's hard to tell the difference between the two. If they're thinking, how can I look like I'm having some difficulty with attention? And in contrast, an easy item in this sort of test would be characters of different species. And they may think, okay, well, that's maybe too obvious. I'll go ahead and select the correct answer for this one. And when you have a binary choice, you basically have a situation in which if the score is low enough, you're getting into chance levels. So if you have a total of 24 items that are difficult, in quotation marks, then a score around 13 or 12 would be about chance levels. And certainly below that, you get into, okay, clearly there's some effort to do the opposite of what the test is asking. So I come from the experience of having done a lot of full comprehensive ADHD test batteries that take 8+ hours, including the administration, the interpretation, and the write-up. And there is a publication in 2012 that describes one university counseling center's battery. I'm sure those of you who have been trained have some familiarity with a similar battery. These general categories can have different tests substituted, but this certainly is a time-consuming process in general. One of the things I recognize is that as I administered these batteries, there tended to be only a certain selection of tests that actually seemed to be differentiating among the students who are diagnosed with ADHD or not, and some redundancy in the tests as well. So again, I want to remind you, you have access to these slides in that toolkit, and I'll be giving that URL as well, so you can easily get this information again. I'm going to go on to the next slide, which does have some of the remaining categories of tests that this particular UC or University Counseling Center has used. And I want to point out that, actually on that last slide, of course some of the basic things are in step 8 here, where you would want to make sure that if you're using the DSM-5 criteria, you would have onset prior to age 12, and you'd have behavioral observations involved and so forth, impact in at least 2 areas of functioning. So what we've done, and you don't need to know the details of this slide really, but we've, in the red box, really kind of emphasized we're not going to proceed with testing unless there is some indication of childhood onset. It doesn't make sense to pursue unless you've got the criteria basically looking possibly fulfilled. So what we do at CAPS does include all of those categories, but with the addition of a symptom validity test. So that relatively comprehensive battery did not have a symptom validity test. So we do include the Victoria symptom validity test, the VSVT. And of course, there are other good ones out there, but we opted for the one that is computer administered just to minimize the time drain away from other clinical resources. A lot of places will use executive functioning measures only as needed, and we've chosen to do that as well. So we may not, as a standard practice, employ an executive functioning battery. I'll go into some of the details of this, but I want to give you just a sense of the overall process that we've developed so that we minimize the amount of time that goes into this. So typically a student is already going to get an intake when they access our services. And ideally, if we know that the student is considering getting services for ADHD, in particular medication, then we'll try to assign that intake with a person on the ADHD team. But that may not happen. In fact, it is possible for a student to access our psychiatrists without coming through a psychologist first. But so if a psychiatrist does a full intake evaluation, then we may go directly into a consultation that is 20 minutes with a member of the ADHD team. And if it looks appropriate to proceed and the student consents to the testing, then the student can be scheduled for testing. And that's basically handled, the testing itself is handled by support staff setting up the tests and the computers actually administering the tests and generating reports. And then those reports are given to the person on the ADHD team who's going to give a feedback session and write up the report. So there could be as little as 40 minutes of in-person direct contact between the ADHD team member and the student in this case. But the testing itself is in a 3-hour block of time. And when you include having a report write-up in the time, the estimate is that it may take about 1.5 hours for both the consultation time and the feedback session, as well as the report write-up, because we've automated a lot of the report writing. And that's in contrast to what I previously was familiar with doing 8 hours with each student. And I do want to again remind you that the intended audience is those who may not be able to do any testing because of limited resources, I'm suggesting that you could begin to actually employ some testing without really draining clinical resources. And if you're already doing a full battery and you've got the resources for that, that's excellent. One of the tests that we use is the CPT-3. I did previously use the CPT-2, and I do like the improvements in the CPT-3. For one thing, with the CPT-2, there often was a 50-50 sort of result on the confidence index, and I see some nods of recognition that there are interpretive guidelines for what to do in that case. But the CPT-3 seemed to really refine that quite a bit, and I'm pleased with how they developed that. And in case you haven't seen this before, there is publicly available demonstration video on the CPT-3. So let me see if I can show that to you real quick. Okay. And one nice thing about the CPT-3 is that you can have either an initial assessment or use it to track progress of treatment over time. You can issue it multiple times. And it's got a nice set of variables to consider in the 14-minute administration time. So this is a test that is using the computer to time responses and accuracy. For this particular instruction, basically the participant is told that there will be letters flashing on the screen, and you're supposed to press the space bar every time a letter flashes, but refrain from doing so when an X flashes. So among other measures that can give you, for example, an indication of impulsivity, if someone does choose to hit the space bar even if the X flashes. We also chose to use the PAI, again, because it is computer administered and it does have a computer-generated report. And the PAI is very useful for looking at other possible explanations for the student's concerns. And it also has a validity measure. I was originally trained with the MMPI-2, and I think it's a great instrument. But the PAI is briefer and less expensive than the briefer version of the MMPI-2, the RF. And I'll show some pricing information in a moment. And so our expense budget to start things off, the fixed one-time expenses totaled to $1,634, and that's with a 40% training site discount. So as a training site, that's a pretty significant discount. So you get the PAI, the VSVT, the CPT-3, and there's the general ability measure for adults from Pearson, as well as the basic achievement skills inventory. And those are, again, computer administered through Q Global. But the cost per administration is about $10.80. And much of that is the IQ and achievement testing as a screener for an LD, a learning disorder. So there are unlimited administrations of the VSVT and the CPT-3. So, one possibility, if you wanted to set aside the question of screening for an LD, you could basically considered this to be a screening and use the CBD3 with the PAI and the VSVT. And the administration time total for that would be about 90 minutes for the student. And of course, the cost would be about $2.40 per administration. So in a sample of 33 cases this year, which excludes 6 cases that had basically incomplete results, or meaning they dropped out of the testing process, and excluding the 12 cases with insufficient effort, we had 13 given an ADHD diagnosis, and many of the others were identified as actually having an anxiety disorder or a depressive disorder, and then were treated appropriately for those conditions. Interestingly, kind of along the lines of the social justice issue, when we examined the gender of those who were getting the diagnoses of ADHD, we saw that there's a pretty strong effect size towards women getting the diagnosis. And so a hypothesis is that many of the women who were coming to us for help had not yet been diagnosed with ADHD, and in contrast, many of the men had already been diagnosed and thought they still had it, but actually they had matured out of the diagnosis. So that was a pretty significant effect, and relatively strong enough for a small n to have a statistically effect, significant effect. And so generally, we if you contrast with a system that involves just having a clinical interview and maybe self-report scales for a diagnosis, we believe we've improved the accuracies in our evaluations. And I'm also contrasting with the referrals we used to make off campus for diagnoses. There just isn't a lot of consistency in practice among the clinicians. And for one thing, probably the most striking is there isn't much use of a symptom validity test out there. So it's hard to tell, if a student is really motivated to get the diagnosis or keep the diagnosis more than anything else. And in many cases, we're also identifying the true cause of symptoms or distress. We're looking at depression and anxiety, for example, and identifying times when, the student actually had a sleep disorder instead of ADHD. And presumably, with better diagnosis and treatment, we're improving outcomes for students and reducing risk of abuse, and doing so in a way that's relatively efficient. We're allocating resources in a way that's not a huge drain on the other very important resources, like psychological counseling, psychotherapy. And we're moving in the direction of where the emerging standards seem to be going. So this is the toolkit that I mentioned earlier. Feel free to download the resources that we have. It's basically a Google Drive location that this tiny URL address points you to. So these slides are already there, as well as an overview of the ADHD testing procedure and a caregiver report that we also use an electronic interface for. So we at UC Santa Cruz have a business account with Google, and they provide a secure server for us to be able to send a link to parents and other caregivers to rate their children's difficulties in childhood and currently. I'll show you these some of these in just a moment. I also put in a PNC report writing template for OpenChart that has a lot of checkbox options that loads in language relevant to that checkbox. So I'll demonstrate that in a moment. And there's a sample report coming from that template, an FAQ for students, and we also really want to try to minimize students' temptation to fake bad. Ideally, we'll have none of our students, coming up with an inconclusive result due to the symptom validity testing. We want to really caution them and inform them that it's important to do your best. So there's a little language on what we say to students along those lines. And I did not include in the toolkit testing setup instructions because the toolkit's publicly available, and the instructions could, if in the hands of a student doing the testing, give them some knowledge of how to break the sort of lockdown that the tests have, so that students can't get in to see other people's reports or see their own results, that sort of thing. So if you're interested in getting those very detailed step-by-step instructions that you could have a support staff use in setting up the tests and downloading the reports and loading them into PNC, just contact me. I'll have my email at the end of this presentation. So let me show you some of those resources here. All right, this is the caregiver retrospective report, as we call it, that has instructions, a description of confidentiality, and identifies their relationship with the student. You may recognize some of these questions as being adapted from standardized measures. So it's a pretty comprehensive history and gives us a lot of information without requiring us to talk to a caregiver and take a lot of time to gather all this information. And by being electronic, we don't have to wait for snail mail to deliver the results to us. So the turnaround time theoretically could be within a week for the results getting to the student. So we have both childhood and current behavior measures, as well as a lot of developmental history gathered as well. And multiple domains, specifically looking at school history and any prior assessments the student may have got. And of course, we will look at tests that we receive and determine whether or not they meet our criteria. If there's one little measure we'd want to include, we will go ahead and just update their results from the outside testing report, and that can be done pretty easily. So that's the caregiver questionnaire, and here's a sample report. This is basically building upon the template that is a UC standard for us, where you do have a psychological testing report, and we've brought, in order to make it more like a full testing report, we've brought in information from the intake here. So there's no need to rewrite what already has been written in the intake. And you don't have to do it this way, but if you do want to have the students' direct answers to the ASRS or some other self-report measure, you could do that. We added a few items at the end about traffic tickets and if they've been treated for ADHD in the past. History of presenting concerns, and familiar options for general clinical history. There's a methods where you can simply select the instruments that you use section, mental status, and then a section looking at the caregiver report that was received with options you could select, and then you could just summarize what the parent or other caregiver had indicated. Checking a box for the different options for the CBD3 also loads in some language, and you can cite other sections of the report to bring in more results as well. The PAI also has an interpretive report that you can cite and pull in, but that's an instrument that we tend to adjust the report a little bit more. A lot of students, for example, will endorse a thought broadcasting item thinking that someone being able to read their facial expression is what the question's asking about, but they're not psychotic. So we're not just blindly copying and pasting the report in here. But this is text from the PAI, and it's cited automatically in the template. And there's a section on looking at IQ and achievement as a screener for LDs. So the achievement measure has a math skills section and a verbal skills section. And then a summary conclusion section with an automatic text that includes a description of what the assessment involved. And actually, theoretically, this is the first point at which you may need to write something in this report. So all of this information up to this point, up to this paragraph here, could be computer generated or coming from the intake. And then even the recommendations are pretty well spelled out. You could choose these sections and it'll populate the details of this. And so I do want to show you a little bit of the interactive part of this. Let's see. Okay, here we go. Oops. All right, so I'm remoting into PNC here. Okay. So this is the template from which that report was derived. So you can indicate if you've pulled information from the intake. You can check a box, paste information in. You can select which tests were used. You can specify the source of the mental status, confirm that there was no ADHD medication used at the time of the testing. And so here's the section for the collateral information from the caregiver report. So you could choose, any of these options here. If you choose the option that the results were consistent with ADHD, it gives you some additional options, and you can select the relevant ones here. So it's loading in the text that is relevant to the student. And we chose not to name the VSVT as our symptom validity test. Some neuropsychologists are choosing to do that just to, again, protect test security. And so, choosing any of these options regarding the student's effort level will provide more detailed description. And again, this is available for you to adapt for your own use if you'd like in that toolkit. Same for the CBT results. There's a description relevant to whether or not the results were valid. and the PAI section, as well as the LD screener. So there's some standard language introducing the IQ measure, and you can paste in, the results of the report. Yes, question?
I think it's remarkable to be able to cut down the number of hours, and that's one, I'm a psychiatrist, and one of the great challenges is dealing with the question of ADHD and having no one in the community who's available for able to do testing using student insurance. So my question is this: how does this compare? You had that data about, what numbers of students who were diagnosed with ADHD based on this assessment. How does this compare, or you may not know the answer to this, but to the traditional full battery of testing that one would have done, or that would be? I mean, I know that ADHD is a clinical diagnosis, right? So there isn't a standard battery, but how does it compare to what you learned from that standard 8-hour battery?
Oh, I'm so glad you asked. I did want to emphasize that our main goal is to decide whether or not there is ADHD present. And, what we're sacrificing for the sake of efficiency is a lot of detail regarding the nature of the student's concerns. So we don't know, exactly how the student is experiencing ADHD, aside from their self-report. So that's what's lost. If you do have an emphasis on treatment that's very tailored to the student, it may be worthwhile to bring in testing that gives you a little more depth of understanding of what's going wrong, like what are the executive functioning deficiencies the student's experiencing. So we really focus on students who are wanting to access psychiatry for medication and validating whether or not they have the diagnosis, and stopped at that point. Yes?
There's a comorbid condition, TBI and ADHD.
Right.
You would never perhaps get to the testing because if they didn't have the childhood onset, they wouldn't be tested.
Yeah, and so, yes, if there were comorbid TBI and the question of ADHD, it would be complicated enough that we would likely refer off campus for that, and we do have neuropsychologists that we can refer to. So, yes. All right. Oh, yes, one more question.
Assume that along with all this very impressive testing, you do blood and urine tests as part of the workup.
Right, and that's all handled by the prescribing psychiatrists. They'll order those labs, yes. So this is more the psychologist end of things, and yeah. Okay, well, that's all the time we have now. Please come up if you have more questions. I'd be happy to talk with you. Thank you so much. Thank you.